Welcome back to the Curbsiders. We had a great discussion with a guest recently, Dr. Albert Hung, and he taught us all about Parkinson's disease. Paul, this was something that really just makes me nervous. You know, neurology, don't have a lot of comfort with that. But he taught us a lot of tips about how to recognize Parkinson's. And one of the things that I hadn't been aware of at all, Paul, were these premotor symptoms. And he mentioned that things like constipation, things like hyposmia, where, loss of sense of smell, and or REM sleep behavior disorder, if patients have those early on and not explained by other things, especially the REM sleep behavior disorder, you should really key in because those patients have risk of developing Parkinson years down the line, and those symptoms could present first, which just kind of blew my mind. For you, Paul, what tips do you have for the listeners about how to recognize it? Maybe whether you want to talk about the physical exam or.
Yeah, well, I love physical exam stuff, so I'm happy to talk about that. I know that you were in particular deeply upset that cogwheel rigidity was not pathognomonic for Parkinson's, but I thought the point about I think that actually you made this point, and our guest agreed, is that asymmetry tends to be the key here. And I actually really appreciated the point about the reemergent tremor. So Matt, I don't know if you remember, there's this idea of a resting tremor, whereas if someone who might have more Parkinsonian features, so the resting tremor you might see with Parkinsonism, you might see an intention tremor with essential tremor. But if someone with Parkinson's reaches out, it might seem steady at first, but if they hold long enough, then the tremor may kind of reemerge. And so I thought that was actually a really sort of neat distinction that I don't think I would have thought about or would have occurred to me prior to talking to our excellent guest. And then this idea that cogwheel rigidity, which it's important, like I also just because I think it's cool, is this combination of some of the cardinal features of Parkinsonism. So it's a little bit of tremor and a little bit of the rigidity too. So there's this baseline increase in tone, and then the tremor superimposed on top of that. And so when you're feeling cogwheeling, that's actually what you're feeling on examination. Like all of Parkinsonism with all the physical exam findings is something that always fascinated me because I think if I last count, I think 27 million of them. But like those were the features that I thought are the ones that we talk about, but I thought the distinction's really helpful.
Yeah, absolutely. He also told us about some red flags because uh, this classic idiopathic Parkinsonism, there's asymmetric involvement of the tremor classically. So things like having a symmetric tremor, that could be one of these red flags that maybe it's something other than idiopathic Parkinsonism. But he also mentioned that one of the reasons you may get an MRI or want to get imaging, which is not always necessary if someone has a classic presentation, is if somebody has like this lower body predominant symptoms of Parkinsonism. So they're really just having the rigidity or the slowness of movement in their legs, but their upper body is not affected. They don't have the masked facies or the tremor in their hands. You may get an MRI in that case because that could be a presentation of vascular dementia or just vascular disease in the brain, or NPH, normal pressure hydrocephalus, Paul, and that is a treatable condition. So you don't want to miss that. So that would be one reason to get imaging, which I thought was really good. And there's a lot of other red flags, which people can listen to the full episode to hear that. But Paul, what if someone was exposed to a drug like a dopamine antagonist? They'll get better in like a couple days, right? Am I right about that?
Yeah, no, I love this. No, I thought this was a really fascinating point because you'd think if this is a drug exposure, if this is a drug-induced Parkinsonism, you stop the medication or the drug or the exposure, and the patient should get better in a couple of days. It's out of their system, right? But it actually turns out that it might take much, much longer. And the mistake that Dr. Hung said that he saw is that you might stop a possibly offending agent, not see any relief of symptoms immediately, and then assume that wasn't the cause of them. But you really have to give them their fair shot off the medication just to experience recovery because those symptoms can last for I think he said up to weeks at a time, if I'm not mistaken, maybe even months.
Yeah, he even said months. So he kind of looks at their problem list and he's like, is there any reason they might have been exposed to one of these medications? And then he'll specifically ask. We're not going to get too much into treatment here, Paul, the specific Parkinson's treatment, but I did want to mention that exercise is one of the things that I was glad to see that he said actually it helps improve mobility and maybe there's even some neuroprotective effects. He mentioned there's some ongoing trials with that. So always love an excuse to tell patients that they should be moving around more and being physically active.
Yeah, I think that was probably one of the more shocking parts of this to me is that exercise might actually be good for you. So I was stunned and surprised. I think that will deeply inform my practice. But it's nice that we have one potentially because a lot of the treatments that we use, none of them um, they all address symptoms. They do not address really progression or sort of fix anything. But exercise
Right.
actually can help with that stuff.
And Paul, the last point I wanted to ask you about to bring us home here in primary care, I mean, patients with Parkinson's, I hear they have some autonomic symptoms, they have some neurocognitive symptoms. What is our role in that as primary care physicians?
Yeah, well, it's for better or for worse because there are so many myriad symptoms that come along with Parkinson's. And we have a lot of experience with most of those things. I mean, we should all feel fairly comfortable dealing with constipation, which can be a very bothersome symptom, and we can use the full arsenal that we have. Things like depression, anxiety, and even the apathy, like the anhedonia part of things, which apparently can be the predominant feature. Like we do have the tools to address, and I actually appreciated the specificity. Like this might be something where you might reach for ibupropion or TCA, which might not be your initial choice for somebody else with a possibly underlying mood disorder, but for someone with Parkinson's, this actually may be very helpful. So we we know how to manage a lot of the symptoms that come along with Parkinsonism that are not just the motor symptoms, and we should sort of take pride and take ownership of those things.
So, if you want to hear the rest of this episode, you can click on the link in the transcript below. And with all that, this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
Yeah, I forgot that we were doing it in this order again, but yeah, no.
All right. Until next time, I've been Dr. Matthew Frank Watto.
I remain Dr. Paul Nelson Williams. Thank you and goodbye.